that may arise due to an eating CASC for anorexia nervosa. And what I want to try to do is to look at how we can think about anorexia nervosa for CASC. And my own personal objective is that at the end of this hour we have together, if you see any question in exam that has to do with anorexia, you're very comfortable, you're very confident, you think, yes, this is 100% pass for me. And I'd like to start by saying that, well, if you want to look at other resources, other helpful materials that can be very useful for exam, you've got our website here for CASC. And also we have a mock exam on the 6th of January. It will be useful for you if you can, if this is something that interests you. It's benefited me in the past, and I think I'll recommend it anytime for everyone. Okay, so that aside, one moment, I need to let someone in here. Okay, right.
The mark is how much?
We can discuss this afterwards. I want us to like spend this. No problem at all. I want us to just get done with this as soon as possible. Please hold on a second. I'm trying to let in a few people in the lobby, and I'm getting a bit distracted by that. Yes, okay. Please, admin, let in the guys in the lobby. Okay. Right. Okay. Can you see my screen?
Yes.
Okay. So my thoughts around anorexia generally are that we will be able to think through how to manage these stations together. And classically, there are 3 or 4 stations. One of them asks about history. There's another one that asks about prognosis, and there's a third one that asks about refeeding syndrome. And what I consider as my top tips for this sort of stations are that we want to give very short answers, concise, short answers that are to the point, that are not verbose, and are not laden with medical terminologies. And then sometimes they want us to make a diagnosis. So you want to gather information to be able to make a diagnosis. And generally, to be able to make a diagnosis, you want to do a quick reflection, a quick summary, and then you tell the patient that based on his history, based on his mental state examination, based on his physical examination, and if you've done any blood tests, based on the results of the tests you've done, you feel that anorexia or schizophrenia or whatever it is you're treating might be the case here. When you're giving answers, once you have to talk on and on and on, once it is long-winded, then you're probably not telling the patient what you should be saying. So please, can I ask of you, anyone at all should help me list, the headings of when we take a psychiatric history. You want to take presenting complaints, history of presenting complaints, past psychiatric history, past whatever history, as we normally would do it. If you can list it in the chat, please, if you have time. This is going to be useful for us when we're doing prognosis. I want us to be as involved in this as possible. That's why I put this here. So if you can list all those headings from top to bottom, it will help us in answering one of our clinical scenarios. And in thinking about anorexia nervosa generally, away from the very technical way in which the ICD-10, ICD-11 explains it, I've tried to express it in a way that it's easy to relate to. So we know that anorexia generally has got to do with people who have a preoccupation with being fat. Hence, they have a morbid fear of being obese or being fat. So because they have that fear of being fat, they avoid foods that are fattening, right? As those foods are being avoided, then they lose weight. And when they lose weight significantly, their weight becomes less than 15% of what is ideal for their body weight, or less than 17.5 BMI. Now, people who have this problem because they are avoiding foods, and we know that our hormones, those chemicals in the body, are products of, good nutrition, good diet, and everything we get from foods. Hence, they will have hormonal problems, including sex hormones. So when a lady has, or a woman has problems with sex hormones, then it means she might have amenorrhea, she might have reduced libido, and then in men, the man may also have reduced libido and impotence. So if we explain anorexia as, a mother has asked me, oh, why do you think my child has anorexia? And I'm explaining that, looking at the criteria from the ICD-11, which we use to make a diagnosis of this disorder, and we see that your child has got a preoccupation with being fat. She's very scared of being obese. So she's avoiding foods that can make her increase in weight. Hence, her weight is less than by 15% of what is expected. And so this thing we do that we calculate by looking at the ratio of the weight and the height, of which we do the height twice. And then also we look at the hormonal changes in her body if we've done an assay, considering also that she has amenorrhea or she's got a reduced libido. We think she has, on that basis, then on the basis of the physical exam, so this is history now, then physical exam, the mental state, I think this lady has got anorexia nervosa. So this is a very, in my view, simple way of trying to explain it. And you can adapt this to suit you. So for the clinical scenarios in CASC that I'm familiar with, we might need to make something like this at some point. And we can go straight into what the clinical scenarios look like if there's anyone who would like to give it a try. So here's the first case I have here. I hope we can do 3 within the next 1 hour. And after going through these 3 stations, I hope that we can be very comfortable in dealing with tasks to do with anorexia nervosa. So do we have any volunteers at all to just try the stations, please? And here we're going to be talking about the history of this patient. So when we discuss the case, the outline for how we want to do our history taking stations will be revealed. So anyone, any takers? You would have 90 seconds to prepare for the station, and then 7 minutes, and then I'll warn you when it's 1 minute to the end. Is there any volunteer?
Yeah, I put my hand up, but my camera is having a problem. I can't, I don't know why.
Okay, not a problem at all. Admit. Okay. Dr. Dube, is that? No, I can see Dr. Dube. Do you want to try?
Yeah, it's me, but my camera is having a problem.
Oh, so you can't see the screen. You can't see the question. I can see the screen,
but you can't see me.
No, I can see you.
Oh, really? Oh, okay.
Yeah, we can see you, Dumi.
Oh, wonderful. But on my laptop, I can't see myself.
Oh,
yeah.
That happens sometimes. That happens.
Yeah, okay.
Okay. And also because I'm also struggling to see. Let me see if I can find my CASC thing. Okay. Right. Can you read it as it is? Are you able to see it, Dr. Dumi?
Yes.
Okay. So time starts now. 90 seconds. Let's go. Right, it's time up. And would you like to start?
Hello, Miss Rebecca.
Hello.
Hello, my name is Dr. Anachi. I'm one of the mental health doctors in the clinic today. Your GP has just referred yourself to come see us because he's a bit concerned about your weight loss.
I
Yeah.
see.
All right. Okay, Rebecca, I'm just wondering if you'd like to tell us a bit more about what's going on.
Yes, I have found myself wanting to lose weight, and I've been able to do that successfully over the past year or so. So I'm very pleased with myself where I am now.
Okay. So can I ask, you said you've successfully done that. So how much weight have you lost over the year?
I think over the last 6 months, I've lost about 20 kilograms.
20 kilograms. And do you know what your current weight is at the moment?
Yeah, I do. Currently, I weigh about 65 kilograms.
Okay. All right. And this weight loss, I'm just wondering, you said it was something you wanted to do. Is it fair to say that it was intentional?
Yeah. I mean, I like to look slim and also, yeah.
Okay. And when you started, trying to lose weight, did you have any target with your mind or anything?
Yeah. I'm actually aiming for 50, so I'm hoping to lose another 15 over the next 6 months.
Okay. All right. Can I just ask, was there any reason in particular that you wanted to lose this weight?
Well, to be honest, I just don't want, it's not fashionable to be big or fat or, so I'd rather be slim and trendy, to be honest.
Okay. Okay. And I'm just wondering, is that the only reason why you wanted to lose weight, just to be, slim and trendy, or did anything happen?
I mean, no, nothing happened. But to be honest, I'm quite fearful of getting fat. I don't want to get obese or big, So when I was 70 kilograms, I mean, my BMI at that time, I used to check it. I know what BMI is. BMI was about 22, which I think was just a bit too much. Yeah. So I want to come down to about 16 or 15 if possible.
Of the BMI?
Yeah, of my BMI.
Yeah. All right. Do you know what your BMI is now?
Now it's just about 17.
17. Okay. All right. And you said you were trying to do you successfully lost weight. Can you tell me a bit more about what you did, to lose weight?
I don't eat a lot of food. I've been eating more vegetables, and that's just once a day. I fast on alternate days, and sometimes sometimes, not all the time, if I feel I've eaten too much, I might just take something to flush out the food. And of course, I'm an athlete, so I exercise a lot, so that has helped me a lot as well.
So you told me quite a number of things, Rebecca. You told me that you've been restricting your diet, if that's correct. Yeah. And you've also been using some medications, to flush things out of your system. And you also told me that you're an athlete, so you exercise. Yeah. Can you tell me a bit more about what you do in terms of exercise?
Well, I lift weight and I run. I run 20 kilometers every day. I do weightlifting every day, and that's about it.
Okay. And so it seems like you're also doing a bit more exercise.
Yeah.
Okay. All right. Can I just ask you a few other questions, if that's okay?
Yeah, sure.
You said whenever you eat and you feel guilty, you take some medications to flush your system. I'm just wondering, have you ever done, try to induce vomiting? Is that something you've done before?
No, I don't do that.
Okay. All right. And it's not unusual for people trying to lose weight, to take some medications that could help with weight loss. Do you find yourself taking those weight loss pills?
Well, I've taken this Ozempic or something for recently I've been taking that.
You've been taking it. Okay. How often do you take this medication?
daily.
Oh, I'm just wondering. I'm quite concerned. Where do you get this medication from, Rebecca?
Well, I buy it on the internet.
Buy it on the internet. Okay, that's quite concerning for us, Rebecca. Yeah. Okay. And again, okay, so since you've lost weight, I just want to ask, how have you been feeling in yourself?
I've been feeling good, to be honest. Yeah.
Have you felt like maybe tired?
No. I feel it's an accomplishment. On the contrary, I feel more energetic and buoyed by my success.
Okay.
And people like it. Everybody around me seems to like it, so it's great.
All right. Okay. So no dizziness, no racing heart rate?
No. Nothing like
okay. That. I'm just going to ask another question, which may be a bit sensitive. I'm just wondering, how has your period changed since you've lost weight?
Oh, well, I've not had a period in like 8 months or so. So, but I'm not bothered about that. That's fine.
Okay. All right. Again, thank you for sharing all this with me. And I'm just wondering, this, trying to lose weight, is this something that you have done in the past before? Oh, dear.
Yeah, I did in the past, but that was a long time ago.
Oh, okay. A long time ago. How long ago was this?
15 years or so, 10. I can't remember.
Oh, okay. All right. Okay. And I'm just wondering, aside myself, have you seen any other mental health doctors?
No.
No. Okay. And do you have any medical conditions you'd like us to be aware of?
Oh, 1 minute. No.
Okay.
1 minute more.
All right. And okay. I'm just wondering, how would people around you describe, your personality?
Oh, well, people find me very friendly and outgoing. So yeah.
Okay. So you did tell me, Rebecca, that you were overweight, or you thought you were overweight. You were 70 kg. Yeah. And then you thought you were a bit fat. And then now that you've lost weight, you're getting a lot of compliments from people and everything. Okay. And I'm also a bit concerned about how you were getting your medication, Ozempic. Yeah. So this is something we can, do a review.
It's a good medication. I buy it on the internet.
Yeah, so something we can arrange a review to discuss about a bit further, because I'm a bit concerned about that. And I'm just also wondering, this, drive to lose weight, do you think it's yours, or is it you're being controlled by somebody else to lose this weight?
It's my personal drive. It's mine.
Okay. All right. Okay. And how has your mood been in all this?
Great. Thank you very much.
Jesus.
Jesus. Okay, so we need to look at the task, because I think probably the task escaped you a bit. So you want to get my history with the aim of establishing a diagnosis. Please assess for etiological factors. So I think for what you did, you've done it very, very well, but maybe you need to be a bit more speedy and also to be mindful of what the task is. So you want to establish the diagnosis, which you did, then establish the complications, which you did, tried to do, but I was hoping to hear something also about what I've had thoughts about hurting myself or anyone else.
But
that was a good risk of buying stuff online. And then, the etiology, you want to be clear and ask me whether I have any biological predisposition, because etiology, as we know, is biopsychosocial. So family history, history of prematurity at birth, if I have that information, psychological factors such as my personality type, which you did manage to ask, and what age am I? I think I'm 28 in this station, so yeah. But I did say that I had one episode about 10 or 15 years ago,
which was if you had been diagnosed with it previously.
So that was in my adolescence, and that's common because of tensions, social and sexual tensions during that period. And then maybe you want to ask me a bit about my family as well. Okay. So, but it's not a problem. Let's quickly talk about the structure of history taking for anorexia and for many other disorders. So we want to ask, one, what is the problem? Well, I've been losing weight. Okay, right. Then you want to ask me a bit about what happened before I started losing the weight. So, Rebecca, when did you start losing this weight? About 6 months ago. Okay. 6 months ago, did anything happen to make you decide on that? Oh, yes, I was stressed. My boyfriend left me, blah, blah, blah. Okay. So you started losing this weight 6 months ago. Has it been getting better? Has it been getting worse? Have you lost more? How much have you lost? All those questions you ask me. Okay, how do you do it? You know, all those questions you ask me. Do I know about my BMI if I'm aware of what it is? I'll say yes or no. Okay. And what is it now? What was it before? Have I noticed any changes in my body? So this is you asking around anorexia. Then you want to ask me, this desire to lose weight, how has it affected my personal life or work life or family life or social life? Then you want to ask me if I've had any complications. Then you want to say, well, sometimes there are many reasons why people want to lose weight. Some people would want to lose weight because they hear voices or they feel controlled to do so. Is that the case with you? I'll say no. Well, some people, when their mood is low, they lose weight. Is that the case? Okay. Some people, when they have, so you are ruling out differential diagnosis. Some people, were very big and they used to eat a lot. And because of that, they want to go the opposite way. So in this sense, we're talking about bulimia, wanting to transit to anorexia. I'll say no. So that's differentials. Then you want to do the etiology, biological, psychological, and social. Family history, prematurity for biological. Psychological would be, did anything happen to me in the past that made me feel, losing weight is a good thing to do? I'll say yes. When I was sick, I was a child, I lost some weight, and then I went to school and everybody was so happy with me, they praised me for that. And then, of course, everybody wants to be slim these days. I want to be like Beyonce or whoever it is I want to look like. And then you ask about the social aspects, about my family. What's my family like? Are they stressing me? Do I have any stress going on now? Is my family one in which there's a lot of high expectations? So one has to be very, very speedy. Then you say, okay, so well, you'd like to do a quick physical examination for me after this session and do a few tests, including full blood counts, ENU, ECG, just to check the state of my organs, but your impression is that I have a condition called anorexia nervosa, which, according to the WHO, is defined by a few things that you've identified in me, including my fear of being fat, this. You just continue to state it like that. And I think that's the general structure that's useful in anorexia. Have I been talking to myself? Does someone want to say a word or two about this before we move on to the next station? Any questions or clarifications or additions?
Thank you for the overview of everything that I just gave now. Quite helpful. Yeah.
Thank you.
I also want to point out that bulimia is important to spell it out very well when we are doing the history.
Yes. Right. Yeah, that's important because bulimia and anorexia usually, and we'll see it in where we're doing the prognosis. Someone who's had a bulimic episode has a worse prognosis than a pure anorexic. Yes. Thank you very much, Doctor. Thank you. Okay, so we want to look at the second station.
Sorry, Dr. Ahmed, let me just
yes.
Something.
Yeah.
For this particular scenario, is it also important to ask all those stuff questions, all those SCOFF questions for this particular scenario?
Is it important to ask what?
You ask a question, not SCFF question. Have you ever been sick in the past? Have you ever tried to make yourself sick?
Okay. Oh, SCOFF, right. Okay. Yeah. So I'm not very familiar with the SCOFF thing itself. However, in the context of this anorexia, yes, it's important if you have the time. But the most important thing is to establish the ICD-10 criteria for making the diagnosis. If SCOFF is part of it, great. If it's not, then it will be a useful addition to score a distinction, but it wouldn't be part of wouldn't be part of the
green juice.
You wouldn't fail if you don't mention it, in my view. The important bits for me would be to state what is in the ICD-10 and relate it to the document, saying that, well, as per the WHO, this is the way the World Health Organization makes the diagnosis, recommend to make the diagnosis. Weight loss to the tune of, say, when it's less than 15% of expected body weight, preoccupation with being fat, leading to that weight loss, avoidance of fattening foods, and deliberate actions taken to avoid getting fat, leading to a problem in the hormonal system for women, consequently amenorrhea, infertility, and in men, loss of libido and impotence. Generally, when this exists, the WHO says this person has got anorexia nervosa. So as you go along, there's always an opportunity to put in all those things. Oh, you're talking and say, oh yeah, do you sometimes make yourself sick? Can I check? And he says yes. Oh, that's an important finding. And you move on. Okay. So
well, thank you.
Thank you very much. Okay. So we're looking at a second scenario in which Mrs. Smith, yeah. Right. So the mother here wants to find out about her daughter. She wants to know how you're going to manage, and she wants to know what the prognosis is. Yeah. Is there someone who's going to help us with this station? Who wants to try? Who wants to try? Good, Dr. Cody. Thank you very much. Yes. Let me get my timepiece.
I can't see the station, so.
Oh, okay. I'm going to display it now. Can you see it? Can you see it?
Yes. Yes,
Okay,
now I
great.
see. Should I start reading?
Yes, please.
Thank you.
Shall we spend 2 minutes doing the reading, please? 2 minutes.
Okay.
Please look at the tasks.
Come and take your tablet. I'm not using it.
You mute your mic if you're not speaking, please. Okay. All right, Simon. Okay.
Hello.
Please start. Hello.
My name is Dr. Coley. I'm the psychiatrist in the clinic today. Are you Miss Jane Smith?
Yes, I am. Yes.
Yeah. I see that you're the mom to our patient Rebecca Smith. Is that correct?
Yes. Yes. And it's because of Rebecca I have come today. I'm aware that she's been diagnosed with anorexia, and I was hoping to, sort of learn from you what you'd like to do for her to be able to help out of this situation, please.
Okay, I'll try to provide as much information as I can, Ms. Jane Smith, about Rebecca.
Okay.
Yes, you're correct that Rebecca has recently been given a diagnosis of anorexia nervosa, and moving forward, we'll try to support her by first. We would like to have series of appointments with her, where we will try to understand what she knows about this diagnosis. And then we will see how we can support her as a multidisciplinary team.
Okay, thank you. Thank you very much,
before
Doctor.
we move on, what do you know about her diagnosis?
In fact, that was going to be my first question. I know there's something called anorexia nervosa, and I'm not sure, why do you think she's got anorexia? I'm not sure what's, yeah.
Yes, well, anorexia nervosa is a diagnosis that applies to people like Rebecca who are struggling with eating. It's a form of eating disorder that people who are struggling with eating and getting enough food that their body requires to function optimally. Yes.
Are there any particular symptoms that you see to be able to say, well, this is anorexia nervosa? Because I'm surprised, to be honest.
Yes. So yes, there are some things that we say that make us, arrive at this diagnosis, like her weight, Rebecca's weight, for example. If her weight is below the expected for her height and for her age and the other criteria we look into, so we would get worried. We expect her to have to be within a certain weight. Yes. Yeah.
Okay, but there are many people, I mean, even in my house, who do not weigh a lot. So does it mean that anybody with a low weight has anorexia then?
No, Jane. So what it means is that there is an index we call the body mass index. So this helps us calculate our weight along with the height. But everyone has different heights, and so we calculate this and we arrive at this body mass index. And if your weight falls within a certain point on the index, this is worrying, and this can trigger different assessments and tests and arriving at this diagnosis. Yeah.
I see. But
does it make sense?
It's beginning to make sense, but I'm just a bit confused because I've seen people who, for various reasons, have very low weights, and they tell me they don't meet that index thing you're talking about. So are there other reasons why that you see in a patient why you might think, like my daughter, she's got anorexia? Because I'm really worried about this diagnosis, really.
Well, yes. So aside the weight, there are also some presentations they could have, like people who aside struggling to eat, they could be unwell, they could feel weak in their body, and they could also have certain thoughts, or like being morbidly afraid of food, or having a certain idea of how they should look.
Right.
Yeah. And it could also have some effect on their self-esteem.
I see.
And this could also boil down from early childhood experiences or experiences in their adolescence that could shape the way they think and their feelings towards food. Yeah.
Thank you, doctor. So how are you going to be able to help my daughter, doctor?
Yes, so we plan to support Rebecca by managing her as a multidisciplinary team, which means different professionals come together to see how best we can support her. So we'll have a community team who will go out to see Rebecca, or she can come in to see us, where we will monitor her weight and her feeding. and general, follow up. And her GP could also support with doing some bloods when we need them. And we will also like to get involved with a dietitian who have a meal plan for her, yes, and work with her to see if this works for her and how we can support her eating better in the future.
Oh,
are you with me so far?
I am with you. Thank you very much. Are you going to give her any medications at all? I'm just curious.
Well, if Rebecca is not in need of any medication, we may not need to start her on any. If she doesn't have any other mental health difficulties, do you know if she has any, Jane?
No. She saw that eating disorder doctor, and that doctor said she doesn't have any other mental health problems except this anorexia bit, which you've kindly explained. Okay, doctor. So yeah, I mean, is she going to do well? I'm really worried about her. 1 minute.
Yeah, I can understand your concern, Jane, and I can see how distressing this can be for you, thinking about your daughter. So we will do our best to support Rebecca through this journey, and we are hopeful that she will get better and be able to carry on with her with her plans for the future.
Thank you, doctor. So what are the chances? How do we know how well she's going to do? I mean, I'm just worried. What's the prognosis like in her?
Yeah. So I can see that you're worried about the prognosis. And with Rebecca, I mean, if she's compliant with medication and she's able to follow the steps, and yes, the diagnosis had come. I understand she's 28 years, and she's just recently been diagnosed. Time up?
I'm with you. No, I'm with you.
Oh, okay. So we are hopeful that she will get better, and with support and with compliance to the deaths.
Now the time is up.
Therapy will go well. Thank you.
Okay.
Thank you for speaking with me, Miss Jane.
Thank you very much. And please give me a leaflet to take to be able to remember a lot of things. Now I'll go back to the task. I think the task is for you to address my concerns and do the prognosis. Tell me about the management and prognosis. So I think from the very beginning, we spent a lot of time trying to define what anorexia is. If you look at when we started, we talked about this in this slide when I was saying that there's a criteria for making a diagnosis, but it looks like you probably did not get the question at the time I was asking it. So what I wanted you to say when I was saying, why do you think she has anorexia, was simply to say, well, you might recall, that your daughter has got a preoccupation with being, just talk about these things. This is what I wanted to hear. So we spent the first 4 minutes talking around these things. Eventually you spoke about some of it, but this is the answer to the first question. Yeah, because I said, why do you think she has anorexia? So the response you were able to give me was that she is not eating well and she has lost weight or something like that. Then I said, but there are lots of people in my house whose weight is low. So you want to say from the get-go, because you know what you're dealing with, that, well, actually, to be able to make a diagnosis of anorexia, we have to see in any patient like we have seen in your daughter that she's preoccupied with the idea of not being fat. And so she's been avoiding foods that could get her fat. And as a result, she's lost weight. And that has affected her hormonal system in such a way that she's not even been menstruating, over the past 6 months or so. This is why we think she has anorexia nervosa. Are you with me, Mrs. Smith? Then I'll say yes. Then I'll tell you, oh, I'm worried.
I was worried.
Yeah.
I was worried that, I didn't get the information of how she her symptoms. Right. And I didn't want to say something that the girl did not have.
Okay. I see the problem. But it's a bit like say anybody that has anorexia, you would have to find at least, this preoccupation and avoidance of foods there. And you can ask me and check. So to make a diagnosis, I just want to be clear about a few things. To be able to make this diagnosis, there are a few boxes we need to tick. If you don't mind, I'll ask you about it. Has your daughter been preoccupied with being fat? I'll say yes. Has she been worried about gaining weight? I'll say yes, 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 yes. Then when we go to the management, we want to say, well, what we want to do is to see Rebecca again and take a thorough history from her. And then we'll do a good mental state exam and a physical exam. And our management is biological, psychological, and social management. In terms of our biology, we want to do some tests. And importantly, we'll check our electrolytes, including we'll check some blood salts, including maybe sodium, potassium, and all those things we normally would talk about. And then we'll do a full blood count as well. Then we'll check again if she's got any, as part of the management, we'll check if she has any other existing risks. We want to look at if she has any risk, and that's going to determine whether we're going to manage her within the hospital or outside. Yes, Dr. Dumi.
I'm sorry, I raised it for later, just to ask a question.
Okay, for later. Okay, yeah. So it's biopsychosocial, biological management. We investigate, we do the electrolytes, and if you can remember, there was a time when there was a document they were using for eating disorders called the Marzipan document. That document was replaced earlier this year by something called MEED, and it was published by the Royal College of Psychiatrists. So if you can name drop and say, well, actually, the way we want to manage her is in accordance with the recent publication of the Royal College of Psychiatrists. And they published a document on the management of emergencies in eating disorders. And according to those guidelines, these are the things we want to do. So you've dropped a very good name and a very good document for them to grapple with. Everybody is aware of that document in eating disorders. So according to that document, you want to do this patient, you want to do all those investigations, and then you want to check. You want to do psychological therapy for her. Then you want to involve the nutritionist importantly, and the nutritionist will be aiming to feed this patient adequately in such a way that she'll be gaining only 1 pound per week. I chose 1 pound per week because the kilograms may be difficult to remember, 0.45 or something, but it's 1 pound per week. And that equates to about 300 or 3,000 kilocalories per day, 300 kilocalories of food per day. Then we see if she has any other problems, we will manage alongside, So it's biopsychosocial, long-term, short-term. She might have a CPN. If there are social needs, she might have maybe a social worker or a support worker or something to help her. Biopsychosocial management, long-term, short-term. At the beginning, I said someone should help us write, how we take history. So you didn't get to this part of that question where we're talking about prognosis. Yeah, I kept asking about prognosis. So not just for this station, in any station, the way we prognosticate is the way we normally would do it, when you'd say, well, in looking at, I'm thinking about how, so you've asked me now, what's the prognosis for this person? And I'll say, well, when thinking about the prognosis, I'm looking at the age at which it started. And you said it started when she was 15. So it's quite good that it started early. And she's a lady, so it's better among men than women. I'm also I'm wondering whether she's had any period of rapid weight loss. People who have very rapid weight loss is worse. And then when it started, how long? So, okay, let me reframe. If you are writing a history for a patient, as we normally would do, we'll do the bio data. So if we look at the biology, the bio data of the patient, the age it favors her. The thing started early. Age, gender, that favors her. Yeah. So when we are writing normal history, we do biodata. We write our biodata. So you look at the biodata of the patient. Then we look at the presenting complaint. If the complaint was that, oh, there has been a severe weight loss, then that's not very good. So you'll be talking through those headlines in history taking. I'm looking at the age of when this started, and I think it was good because she's 15 and is good at a younger age group. And you did, I wonder how soon after the diagnosis was made that she had treatment then. The mother will say, oh, she had treatment immediately. Oh, excellent. That's also a reason for us to be optimistic. Did she recover well at the time she had the treatment? Yes. Oh, that's good. When people recover very quickly, then it portends well for the future. Has she had? So now we're thinking about, so we've done the biodata, then we do the presenting complaints. Was there any severe weight loss at the time? The mother says, no, it wasn't severe, but it wasn't very rapid. Was there any rapid weight loss? It wasn't very rapid, but there was a loss of it. Okay. And has she ever had any medical complications at all as a result of not eating? The mother will say, no. Okay, that's also good. But was there ever a time when she was big and would eat and vomit? People say no. Say no. Oh, great. That's also a good indices of prognosis. Does she have, now, we've done presenting complaints, history of presenting complaints. Now go to past psychiatric history. Does she have any other psychiatric diagnosis? No, she doesn't. Oh, that's good. Does she take alcohol or street drugs? Excellent. Past medical history. Does she have any medical problems currently? No. Okay, that's also good prognosis. And then what's her relationship like with you, her mom, and her dad and siblings? Oh, yeah, she's very good. She's a doctor. She's well adjusted, normally good prognosis. Does she take alcohol or street drugs? No, she doesn't. That's also good prognosis. So you try and extract all the good prognosis and say, well, on the basis of the fact that the good indices of prognosis are more and the bad indices are less, I think the prognosis in Rebecca is really very good. You get it? Okay. So that's how we want to look at it. I think if we can look at it this way, we should be fine. Dr. Dumi, do you have a question, or do you want us to try and squeeze in the last one?
I had a question. Yeah,
yes,
sorry
please.
about that. It's I might be taking us back. For amenorrhea, one of the core symptoms is that abnormal body image.
Yeah,
and the fear of weight.
Yeah,
abnormal.
Yeah. So
yeah. So in terms of taking a history, how would you kind of elicit that? Okay, she has an abnormal body image.
Right.
Or body image distortion. Yeah.
Right. So, Dr. Dumi, you feel your weight is not, you feel you're too big and you need to slim down. Okay. Is there any particular part of your body that, you think is not well formed? Do you have any problems with the way any part of your body looks? That sort of thing. Is a bit like you are doing that station on body dysmorphia. When somebody says my eyes are too wide, really. So is there any part of your body that you think is not well formed or something? So I think this is the way we would ask the question.
Okay. Thank you.
Maybe I've spoken for too long. We have about 6 minutes left. Do people want to ask other questions related to these stations we've done? So I can do a very brief recap for history taking. We say that when we want to take history, we ask about Dr. Talabi, why have you come to clinic today? i.e. presenting complaints. He says, oh, I'm here because I've been hearing voices, or whatever he says, because I've not been eating well. Okay, when did this start? It started last week. All right, before it started, did anything happen? Because these things are usually preceded by a program. So they tell us, okay, then you refrain and reflect. Okay, so 5 weeks ago, you weren't feeling very well. You had a headache or whatever. And then 2 weeks ago, you started not eating properly. Is that correct? He says yes. Okay. Then you try and look at how it has progressed and ask, how has it progressed? Is it getting worse? Is it getting better? Is there anything that makes it worse? Is there anything that makes it better? Is there anything that relieves it? Then you ask again, okay, how has this affected your life? He may not understand. You might have to tell him, I mean, has it affected your personal life or your work life or your family life? Then you ask him how he's been coping, whether he's been taking alcohol or not, and how it's affected his mood. And then we'll ask about the complications in terms of suicide, deliberate self-harm, eating, drinking, self-neglect. This is just a story of the presenting complaints. You've not asked about ICD-10 criteria. Then you move to the next step. You want to ask about symptoms that are related to the presenting complaints, and you signpost. So you've told me, Dr. Talabi, that you have not been eating very well. I want to ask you about a few things that may happen when people are not eating well. So because as you're not eating well, is that because you are worried about gaining weight? He says yes or no. Okay. Some people, when they have this problem, they report that their sexual drive becomes lower. Have you noticed that in yourself? And this is you trying to ask about anorexia. Have you been making any deliberate efforts not to gain weight and deliberate efforts to lose weight? He tells you. Then you say, okay, thank you very much, doctor, for telling me all of that. Now I want to ask you about symptoms, about reasons why people have these sort of habits. So now you want to do a bit of differential diagnosis. Some people, refuse to eat because they realize they are very big and then they want to lose weight. So they force themselves to purge, or they use some medications to flush out the food. The guy will say yes or no. Or some people hear voices when this happens. They say, no. Some people do this because they're very unhappy, their mood is low. Is that the case with you? Has your energy been low? Then you go to etiology, bio, psycho, social. I wonder whether there's any member of your family with the same sort of problems. And then you do the psychological bit and the social bit. And, you offer him a physical exam, even if it's a history-taking station, not just for anorexia, anyone. Offer this patient a physical exam after you've had a chat with them. Tell them that you're going to do some investigations and then make a diagnosis and give your reasons. So this is basically how you want to run through that history. Any questions, please? Okay. So it looks like everybody is very happy. Everybody is satisfied. There are no questions. Yes.
Sorry, I've got a quick question, like
please.
About the prognostic factors, because I know there's a station that actually talks about take the positive and negative prognostic factors. So start the station, like how do you introduce that to the patient? Do you kind of just say so okay, I think but there's another one that's where like you speak to the patient directly. So how do you say that? And how do you close? Thank you so much, sir.
No problem. So that one, I also know that station. I think you already have an idea of what the prognosis, what the factors are. So Dr. Talabi, when this problem started, how old were you? Oh, you were 15. All right, okay. All right, okay. And apart from that, when it started, were you treated very early? The guy says yes or no. Okay, so let's say this is the session and we are doing it. I'll just say Mr. Talabi for the purpose of this. Hello, Mr. Talabi. I understand you wanted to talk to me about your diagnosis of anorexia. Is that correct? You tell me yes. I say, okay, I understand. When did this problem start? You tell me. How long was it going on for until you got treatment? You tell me. Then I ask you again. Was it very severe? Was there a period where you had any severe weight loss? No. Okay. Then I ask you, I'm going down now to past psychiatric history. Do you have any other psychiatric problems at all? You say yes or no. Do you have any chronic medical problems? You say yes or no. And how are you with your family? Do you take any drugs? then I'll be like, okay, so Mr. Talabi, I'm looking at you and I'm thinking about how your potential outlook. And I think the outlook for you is really very positive, because although you're a man, which is not necessarily a good thing in anorexia, but you have so many things going for you. First is that this started when you were very young, which is good. It didn't last for so long before you got treatment, which is good. When you started taking the treatment, you recovered very early. You never suffered any medical complications. You don't have any chronic medical problems. You don't have any other psychiatric problems. And you don't even take drugs and alcohol. To top it up, you have a very good family, you're working, and you're well motivated. So I think the prognosis in you is really very good. Do you follow me, Dr. Talabi? You say yes. All right. Do you have any other questions? Something like that. Yes. So I think this is how one can approach that station. Yes. And lest I forget, if we look together at this website for the CASC mock, we'll find details of it on there. You might find that it might cost you only about £350. And I think the good thing about this is that you get an individual debrief after the whole test, and people tell you about how you've done, what you can do better, and how to do better, which I think is really great. I have done it before, and I recommend it to people who who are sitting the exams. So thank you very much, everyone. And probably before the exam, we're going to have another session. But thank you for attending this. And I wish you the very best in the exams and in everything for the future. Thank you so much. Have a good day.
Thank you.
Bye-bye. Thank you.
Thank you.
Bye. Thank you. Bye. Bye.
Very helpful.
Thank you. Thank you. Thank you.
Thank you, sir.
All right. Thank you,
sir.
Thank you, moms and sirs. Thank you. Bye-bye.
Hi. Hi, Dr. K.